contact lens fit assessment using smartphone co-aided cobalt blue photography Y, and the discussant is Kim sir.
Good morning all. I actually have a video to show, so could you please play my video?
There was a time when phones were used simply to make phone calls. Then came this moment, courtesy of the late, great Steve Jobs.
An iPod, a phone. Are you getting it or not? 3 separate devices. This is one device, and we are calling it iPhone.
The world changed that day and never looked back. Smartphones now run our lives, and we have seen smartphone-aided examination and documentation emerging as a new wave in modern-day ophthalmology. We have published of a do-it-yourself device used in conjunction with smartphones for blue light photography of fluorescent-stained corneas, and this device was used to capture high-definition videos and images of multiple corneal pathologies. We extended its use to the world of contact lenses. Optimum contact lens fitting is crucial for long-term safety and compliance, and fitting by assessing fluorescent pattern has been in use since rigid contact lens came into market. We pit our device against the OG slit lamp microscope. We assess contact lens fit using fluorescent staining patterns of 128 eyes using our do-it-yourself device and compared it to slit lamp imaging. The images obtained from both the slit lamp and the do-it-yourself device were randomized and transferred to an iPad, and an independent examiner was asked to diagnose and grade image quality of each image based on the following grading system. We found that the image quality and diagnosis of contact lens fit was comparable between the two photographic devices. We found this device particularly useful as a teaching tool where recorded videos and pictures could be simultaneously viewed by the teacher and optometry or ophthalmology students and discussed. It could also be considered in teleophthalmology, where images and videos captured can be transferred electronically to be assessed by an experienced professional for further discussion and management. So, for your consideration, we give you Scooby Fit, a do-it-yourself mobile low-cost device that could be considered as an alternative to slit lamp for assessment and documentation of contact lens fitting. Thank you.
Thank you. I think it's a good idea to repurpose the cell phone for so many other activities. Yes, and good, you've taken it from the slit lamp, corneal ulcers, and then now on to this. What is the exact device that you fit onto the slit lamp?
It's a small device, sir. It's actually there's a blue acrylic sheet which is placed on the flashlight of the camera, and an intraocular lens is placed on the camera to magnify the image. So these two are placed together on the camera, and then we can just take the pictures.
So where are the cases where you had challenges in comparison to slit lamp? Was there any particular cases, deep set eyes or any of that?
Yeah,
where
so
you had
IOL depends on the IOL power and how much magnification you need. So I'm using a 20 adapter, so it's actually quite highly magnified. Probably for contact lens fit or probably a little bit higher power, we'll be able to keep it a little bit back also and get a very clear image. This one, it has to be magnified, so the depth of focus is very short. So a little bit movement and it will change the focus. So that's where the challenge is. But if you change the IOL power, then it shouldn't be an issue, sir.
Good. I think it's a good innovation.
Thank you, sir.
How it will be useful for teleophthalmology? You mentioned one slide, teleophthalmology.
Yeah, so teleophthalmology, what I mean is, if there are other centers where there are no cornea specialists or doctors who want to kind of assess this, if they can sort of electronically transfer the images and videos and get an assessment from a more experienced person.
To share the experience, you mean? to share the experience among the
Yes,
students.
yes, sir. So in that way, it could be used, sir.
Okay. Okay.
So the judges, please note you all have specific topics to ask questions to. Each of the judges have been given specific topics because I think we'll not be able to complete if all the judges ask. All judges will mark all, but will ask for specific questions. It's on the group. So for the discussant for the next one, thank you so
Thank
much. Yeah, the discussant, yes, please collect your certificate. For the next one, it's Dr. Sujata Mohan, but because it's not there, madam, maybe you can ask a question.
So next we request Dr. Prithvi Chandrakant.
Good morning, good afternoon all, good morning all. I'll be presenting I have no conflict of interest and no financial interest in my presentation. As we all know, retinoscopy is an objective refraction technique, which is very skill dependent, and the worst part is it is very difficult for the initial residents to actually get this skill and to understand what the mentor is actually telling. And there are no live demonstrative instruments until now to record or to even show the residents how the reflexes look or to teach them, and it becomes very difficult, and it becomes a very large learning curve we'll require to make them understand. So over here, so we use a schematic or model eyes to actually demonstrate, and there are no video libraries showing actual live demonstration of the reflexes. And this becomes a very big problem because it increases the learning curve. So over here, like you see, when we say with the movement reflex or we say against the movement reflex, it's little difficult for them to understand, and it takes some time for them to understand. So so over here, what we did is, we thought, why not use a smartphone, and why not use a smartphone in a way that a gimbal works. So a gimbal is a small instrument which helps the phone to be stabilized. So we combine these two things, the smartphone and the gimbal scope concept together, and then we made the gimbal retinoscope, that is the gimbal scope. So this is the actual thing. These are my co-authors, and I'm Dr. Prithvi. So I will. So over here you can see we use super glue, few adapters, and the retinoscope to attach. This is the way we have made it. So we attach the two adapters together, and the adapters then with the smartphone attached to the retinoscope. And once that is done, we attach the phone to it, and we take the reflexes. We can record the images. We can even take live demonstration and show it to them at the site itself. You can see how against the movement is well demonstrated here. This is the neutralization point, and this is a scissor reflex. So all these are very simple. It's a very frugal and very easy to do thing. So this will so over here we had some limitations in this procedure. So it was actually a little difficult for few people in the initial learning curve to assemble it. It was heavy, and the focusing sleeve was a little difficult to approach. So we thought about 3D printing it. So now what happened is we have 3D printed a small adapter which is so small, and it can be connected to a endo camera. So this was available in the Amazon for 1,000 rupees. So 1,000 plus this small thing actually costs just 100 rupees if you want to 3D print it. So you just fix it to the retinoscope, and you're good to go, and it gives exactly the same quality of the smartphone. And you can even see these images in the smartphone. You can even connect it to the laptop, and hence it is very simple to make resident, and even you can make your own library of all these reflexes. Thank you.
Attach the camera.
The smartphone.
On one side.
Yeah, I have a. So this is the camera which we are using. Yeah, this comes in Amazon. This comes in Amazon. This small, this endo camera, which comes with around 1,000 rupees. You can just put this in. This is actually a 3D model, and then you can just fix it over here. This one, this is the retinoscope, and you can just fix it over here. And you can connect this either to your smartphone. Yes, yeah, it fits. Yeah, yeah, and this same size. This is a high. This is the most commonly used retinoscope. That's a high beta 2000. So this is what almost everybody has, except for some few people use Keeler. So we can design for that also. For now we have this one because this is what we use in our hospital, and so this is fixed. This you can connect it to your computer, or you can connect it to your phone itself. So you have a small adapter which you can connect to the smartphone also. So you just have to download an app and it will show up in your phone. Yes, this is for the phone, this is for the computer, USB device, and this is the actual initial prototype. So this one directly goes to the smartphone. You just have to open this, connect it to the retinoscope, the handle over there. Yeah, this is also very easy. This is the prototype. Yeah, this was the first prototype, and this was the modification. Easier. Yeah.
Arvind Maurya, Dr. Arvind Maurya. Dr. Prashant. Next. Dr. Sanjay Chaudhary. Dr. Chaya, please. Dr. Anand will be the discussant.
Crore worth vantage view of retina by capturing images on Android mobile. I have no financial disclosure. Method, I have used only pan-retinal lens and 20 diopter lens along with a Nokia mobile. I haven't used any kind of these attachments. Technique, it is done in two steps. In first step, images are captured on mobile. To capture images of nasal view, one has to stand on the temporal aspect, while to capture on the capture the temporal view, one has to stand on the nasal aspect of the patient. Similarly, superior and inferior view are captured. The second step, image editing, which is done on laptops. The images are transferred on laptop, and then on PowerPoint, the central image is captured, reduced in size, brought at the center, peripheral image is selected, reduced in size, cropped, taken backward behind the central image. The central image is further cropped. The central image is rotated to align the disc and the vessels. Another peripheral image is selected, rotated, cropped, taken backward behind these two images. To check whether the alignment is proper or not, it is brought forward. Since it's not, the proper alignment is not proper, the central image is further moved here and there, to and fro movements, and then the backward image is then rotated to align the vessels. Thus, the montage is complete. Results. This is a montage of a tilted optic disc where we can see ultra-wide and a high resolution picture. A subretinal lens is with traction retinal detachment where the scholars can be clearly seen. RC coloma with intercalary membrane. A montage of choroidemia. A montage of retinal hemangiomas where 4 foci can be clearly seen. A siliconoid filled eye with inferior retinectomy and a PFCL bubble can be clearly seen. A montage of viral retinitis with macular star. On comparing with the commercially available equipments like Mirante and Claris, these pictures are equally of high resolution and ultra wide field and very clear also. Here also we can see a lasered hole. On comparing with the images of Optos, these pictures are of true colors and no eyelash defect has been seen. Another montage, a comparison. So what are the advantages? It can be used in private setup. They are very cheap in comparison to the commercially available equipments, which will cost you about 1 crore. No CMCs, no overburden, no breakdown, and they can be easily can be carried away, where the Clarus Emerante cannot be ported. So they can be used like for counseling, printing, can be shared on various social medias. Disease monitoring can be done, teaching can be done, storage and documentation. To conclude, it's a simple, easy, inexpensive technique with true colors and high resolution, can be ported also. I have no financial disclosure. Thank you.
Thank you, Dr. Chaya. I just want to know, there are a lot of Android phone and iPhone based devices now, and what value addition over these? For example, the MI cam from Ashish Sharma, the Jazz cam from PG Jaitra. So, what additional value is your device bringing? It was very good with images. We really appreciate the images and congratulations. But additional over these that are already been there for quite some time, what additional value does your instrument device bring?
Sir, it's a technique. It's the technique to capture image and to make a montage. So if you compare with the commercially available equipments like Clarus, Mirante,
No, I agree about Clarus and Optus. We're not
Yeah.
comparing. We're talking of this device, this technology, this thought process has been there for some time. So there are other devices which are already there. In fact, I think the MI cam has been marketed for a long, long time. So what I'm asking you is, you're using the same kind of technology. What value add is your device bringing over those? We understand that this
Yes,
is obviously
sir.
going to be far more cost effective.
It really helps in capturing the images and counseling of the patient. You can do disease
No, those
monitoring.
things I understand. I'm asking my direct and simple question is, what value add is your device bringing over the existing Android phone based imaging? Like I mentioned these two devices, I'm sure there are more. In fact, I just don't recollect their names. There are at least 3 or 4 devices like this.
None
already.
of them are making the montage view. They all are taking
But your
the
montage view is made not on your device, it's made on the laptop, which they are also doing, by the way.
I haven't seen anyone doing the montage also
No,
till
they
now.
have published it also.
Okay, I have also published, sir.
Yeah, I understand. So I'm just
Yeah,
asking this question.
yes,
So
sir.
obviously it is another good device
Yes.
alongside those. Okay.
Thank you, sir.
And other question is, have you showed us great images, but do you have artifacts happening when you do peripheral viewing? Because this is an issue which these kind of
No,
portable
I have
devices
even
have.
captured the aura and the lattice and barrages holes. Even I have captured the white without pressure areas.
Yeah, I saw those lasered holes and others. So you feel you don't have too much of an issue with artifacts, especially with peripheral viewing.
Peripheral view lens artifact is there with every machine also, that you
Yeah.
can remove with your this PowerPoint or any of the app, whichever any person and image editing apps, you can remove those artifacts.
Okay, thank you.
Dr. Chaya, please collect your certificate from.
The next presenter is Dr. Jibint. He'll be talking on FACOSIT. The discussant will be Dr. Mukesh Sharma. He's not there. Okay. I think Dr. Jibint is not here, so we'll move on to the next presenter, Dr. Ashwini Kumar, who will be talking on multi-pronged study to improve vision in hopeless condition at Mahavir Netralaya, Patna. Okay. Since Dr. Arvind has come, he'll be presenting next on disposable sewing needle microcapsulotome, and the discussant will be Dr. Ramesh.
Greetings, everyone. In voice. In this video, we aim to demonstrate our new and effective innovation, sieving needle microcapsulotomy, to avoid Argentinian flag sign during capsulorhexis in patients with intumescent pearly white mature cataracts. Argentinian flag sign is a complication during capsulorhexis in intumescent white cataracts, which typically arises instantly after initial prick by sharp hypodermic needle. It is known that raised intralenticule pressure is responsible for propagation of the initial prick into a radial tear. To counter this, several techniques, including a small needle aspiration technique, had been described, but the peripheral extension of the capsular tear, as is still seen instantly after pricking the capsule with hypodermic needle even before the aspiration of cortex. So, other factor, that is a linear cut configuration with discontinuous open edges with a needle, are responsible too. The disruptive forces act along the axis of the linear curve, so the tear always extends radially along the open margins of the cut, but never perpendicular. So we came up with a hypothesis that if we are able to manually create an opening in the anterior capsule with a round regular configuration like a capsulotomy with round continuous circular edge without any discontinuity, hence do not tear away with a sudden outburst of the intralenticular fluid. To prick the capsule, we developed a novel instrument, sieving needle microcapsulotomy, with round pointed tip like a sieving needle system. Tip is approximately 0.75 mm in length, 0.6 mm in diameter, and angled at 90 degrees to the distal shaft. On puncturing the capsule, it creates a round hole opening with a smooth margins, unlike the linear cut produced by the sharp needle. After proper visco in the AC through the main incision, the sieving needle microcapsulotomy is inserted. Tip of the needle is placed vertically over the center of the capsule. Tip is then moved downward to penetrate through the taut anterior capsule. Round pointed tip creates a round opening with a smooth margins at the center of the capsule. Pressurized intralenticular fluid gushes out as a volcanic eruption through the hole, which decreases the intralenticular pressure and helps in the decompression of the capsular bag. Evacuation of the intralenticular fluid, including the posterior compartment fluid, is achieved by tapping the capsule posteriorly. Again, cohesive visco is pushed in AC to flatten the anterior capsule, and intended 5 to 5.5 mm of capsulorhexis is initiated after tearing the central hole using a rhexis forceps and easily completed without the risk of peripheral extension. To conclude, sieving needle microcapsulotomy with circular round hole puncture of the anterior capsule along with pressure decompression is the simplest of technique which enables us to successfully prevent Argentinian flag sign. Sieving needle microcapsulotomy is simple yet highly effective novel tool and is an ideal device to open up tense anterior capsule to adequately decompress the bag prior to the initiation of the capsulorhexis. Thank you.
Thank you, Dr. Moria. That is a beautiful presentation. I'm here. So I have a few questions. Were you able to manage a proper capsulorhexis in all the patients with intumescent cataracts, or did you have any issues with some of them?
Yeah, we are doing a clinical trial. So we have done 23 cases till now. So we are successful in doing that.
How important are the remaining steps like capsular staining, deepening the anterior chamber, giving
everything.
a good softening the eye?
Exactly.
How good are those steps?
Yeah, those are very important steps.
Okay.
Because I have shown in the video the central tapping and the use of the cohesive viscoelastic. All these steps they have play a very important role in preventing the Argentinian flag sign.
On an average, how many punctures do you have to make to lower the intralenticular pressure?
We are doing one, but if needed, within the 5 mm of the zone, if there are multiple fluid pockets, we can make multiple holes also.
Okay.
Yeah.
So the two things which really work is to make a small capsulorhexis initially and extend, or to make or to do some form of a spiral rhexis. These are the two standard type of rhexises. If your needle puncture is releasing the pressure sufficiently, we should be able to make a normal primary capsulorhexis. So can you do that after you make these punctures? Can you make a normal 5 to 5.5 millimeter?
Yeah, that is
rhexis?
achievable almost every time.
Thank you so much, sir.
Thank you, sir.
Please collect your certificate, doctor. Thank you. Next presenter is Dr. Ashwini Kumar.
Thank you so very much.
Dr. Ashwini Kumar. Abhi. Okay, if Dr. Ashwini Kumar is not there, Dr. Narendra Singh var. Narendra Singh.
If Dr. Ashwini Kumar is not there, we'll go on to the next. Dr. Narendra Singh Verma will be talking on EC-TOR and Easy Complete Toric Solution. Dr. Sriram will be the discussant.
Thanks AIOC, ARC, and Kerala Ophthalmic Society for this opportunity. I present to you EasyTor, an easy complete toric solution which we have developed in last 3 years. Not moving. Slides not moving. Okay. It's okay. So EasyTor and easy complete toric solution. So during cataract surgery, there are two ways to decrease corneal toricity: by toric lens implantation or by incision on the steep axis, which may be SICS, LRI, OCCI, etc. So EasyTor has all important features which are required for preoperative workup and intraoperatively for toric lens implantation. It measures non-invasive tear film breakup time. As a topographer, it provides keratometry in 3, 5, and 7 millimeter zone. 3 millimeter zone is important. It provides axial heat map, so you can find out the nature of astigmatism. It should be regular. It has having manual image guided system, an app for the easy and error-free marking of the axis of alignment of the toric lens. It is having easy and error-free steep axis marking for surgical correction of astigmatism by incision. So EasyTor also provides some new features. It is having directly access to the Barrett toric calculator and Barrett Universal 2 formula. So it prevents transcription error, and it is a fast method. So you don't know to fill all the data. It will directly tell you the readings. It is having real-time data sharing to the multiple device by Wi-Fi. So surgeon can analyze the results when he's in OPD or in OT. There's no need to go in the examination room. So let's see how it works.
It is a topographer with many additional features. It provides an easy, efficient, and economical alternative to existing solutions. It is an LED-based anterior surface topographer which analyzes 600 data points in a 9mm central corneal zone. A single capture provides us with all the required data which is summarized on a single screen. It provides keratometry in 3, 5, and 7mm zones, axial heat map, bite to bite, etc. Demonstration of toric lens axis alignment. Left eye keratometry of this patient shows 1.5 diopter astigmatism in 132 degrees in 3mm zone. Press the calculator icon. Net astigmatism will be displayed directly from Barrett toric calculator. It is 1.1 diopter in 145 degrees in this case. Enter SIA value, which is 0.3 in this case. The axis of alignment will be displayed automatically, which is at 147 degrees in this case. Press the pencil icon to enter biometry data: axial length, ACD, and lens thickness. The axis of alignment at 147 degrees is displayed as a green line, and site of incision at 136 degrees in the form of a pink highlighted area. Identify two prominent limbal structures. Click on it. The system will display their axis. It is 17 and 50 degrees in this case. Save the picture, rotate it as needed, and use it intraoperatively to identify landmark points under microscope. Here, I am making two landmark points at 17 and 50 degrees on the patient's eye. Hold the degree gauge and align it with the markings. Now mark the site of incision, which is at 136 degrees. After lens implantation and viscoelastic removal, bring the degree gauge again to mark axis of alignment on the limbus at 145 degrees using 17 and 50 degree landmark points as reference. You can also mark the axis of alignment on the cornea. Finally, align the toric lens axis with the corneal markings. SCA marking module can be used for surgical correction of astigmatism using incision as a plan B in patients not suitable for toric lens implantation. Demonstration. Right eye is pseudophakic and post-op residual refractive error is plus 1.5 spherical with minus 3.25 cylinder. Even though the IOL power was perfect, the site of incision was incorrect as it was on flat axis. The left eye has cataract with 1.1 diopter cylinder at 175 degrees. Press the pencil icon to enter biometry data in Barrett Universal 2 formula. Then click the calculator icon to get IOL power options with residual refractive error. I planned for 5.5mm main incision at 175 degrees and 2.8mm OCCI to neutralize the 1.1 diopter astigmatism by using incisions. Identify and mark two prominent limbal structures which are at 14 and 168 degree in this case. Intraoperatively mark the same points on the limbus using marker. Using these landmark points as reference, I mark the site of incision at 175 degrees on both sides. After lens implantation, a 2.8mm OCCI was done and the main incision was extended to 5.5mm. These are post-op day 1 and day 6 pictures. Post-op day 6 SIA was 2.6 diopter and 2.1 diopter on day 17, which demonstrates a regression of 0.5 diopter.
Thank you for your time.
What is the display that you're using when you're working on the surgery, on the microscope?
So you can use a tablet, you can use the any device. You can use a tablet, laptop or desktop. It is connected to all the devices, multiple devices you can connect with it.
But you don't really need a tab. You can take a photograph, paste it on the wall, and then use that as a reference marking also.
No, when sometime what happens, you can take the tablet with you in the OT. After putting, when you have put the lens, toric lens, then you see which structure you are able to see and which is there in the topography picture. You will tap on it, it will tell you this is the location. So you mark this point and you can just, these are the reference marks. So, yeah.
The beads, the colorful beads.
Colorful picture.
Beads.
Those are the LED lights.
So these are the LEDs. It is LED based system, light Cassini, but we are having different software.
No, we'll come to the most important part. This seats hardware and software.
No,
what is the cost?
Madam, we have developed this topographer. Since last 3 years, we are developing this topographer. This is our third model. We developed this topographer.
No, we'll have to come to...
It's very risky to put a toric IOL. People pay so much. It's very risky. You get some error.
No, there is... so, it will measure the axis of steep axis and...
we have come to the most important question. There's hardware and software involved. What is the cost?
Sir, we are developing two more things in this system. That P2 with infrared light, we will find out the total TK. We will find P1 and P2 and SDR mode too. So we can, the blood vessel will be more prominent. So after that, we will, everything is not, we are very much, हमको पता लगेगा बिल्कुल एक सब कुछ ठीक है, कोई एरर नहीं, सब कुछ इसमें है और इसमें अभी जो है ना वो NIBUT टीयर फिल्म ब्रेकअप टाइम भी उसमें आएगा, सब होने के बाद उसको लगभग नेक्स्ट ईयर लॉन्च करेंगे. So it is under development.
Thank you.
Maybe 5 or 6. Thank you, sir.
Thank you.
Thank you, sir. Next speaker will be Dr. Ashwini Kumar, and the discussant will be Dr. Shubhra Goyal and Dr. Chaitra Jaydev.
Ashwini Kumar, and I was the best surgeon of Mahavir College, Patna 13 years back. But 13 years back, I had a brain hemorrhage, so I couldn't operate later. So rather than crying, I went to Shankar College, Chennai, and started a deep treatment of visual rehabilitation. Means by which patients who had no hopes that they will see again, they could see better. And this thing is done only by me in Bihar. So I wanted to, now I want to make my second life much more clear, much more meaningful, so that I can help people. What is given me second life, so I want to. So I'm starting to try. Now the intervention I use is telescopes that use the variety of telescopes. There were mobility training, like means M training. Means आपको बड़ा M बनाना है, गर्दन को रोटेट करें, जिससे कि आप किनारे का देख सकें. Second thing, there was signature guide to help in signing, to making signature. Second thing I did was, then I used to go to home with my driver to help people that how can they do the roti paratha and all. They can't make a roti with one hand magnifier. So I change their contrast and projection of light. Sometimes they have all colors also. Thereafter, so this you can see, this is signature guide. He almost left his job because he couldn't see the checks of the card. So I made him see again, and this person is seeing the telescope. So that's it.
How many patients were you able to help?
6 months, I have helped 3,000. Because on Bihar, nobody had the concept of visual reality. Even I didn't know that there is something called visual reality. So जब तक मेरा जरूरत नहीं पड़ी. So I am like, अब मेरे को मैं survive करना था. So अभी मैंने around 3,000 patients taken in 6 months, and most of them thanks to what I had done, and I get lots of blessings. I'm not getting lots of money, but I'm getting lots of blessings. This is much needed. That's why I came to here to speak.
Audio okay. There.
Thank you, sir.
Connecting. Working.
I thank Dr. Ashwini Kumar for his presentation. The next presenter will be Dr. Vivekanandan, who will be talking about his new IOL fixation technique. Dr. Arul sir will be the discussant.
भैया क्या I know how to project the library. உங்ககிட்ட மேத் கேபிள் இருக்கு இப்போதான் கனெக்ட் ஆயிருக்கு இப்போதான் கனெக்ட் ஆயிருக்கு Check பண்ணுங்க. வருதா? Is there? Huh?
One second.
It's coming. Yeah. Flip. Flanges. Why it's the Brahmastra for anterior segment surgeons. So this was first initially inspired by guard procedure done by Devinder Grover and Ronald Feldman, where they use a Prolene suture where the tip is cauterized and goniotomy assisted transluminal trabeculectomy is done. So this led us to the path where we wanted to replace knots with flanges. So these are the indications where I use in zonular dialysis, iridodialysis, and aphakia management. So this is a case of microspherophakia. So where capsule hooks are placed, phacomulsification is done. And then instead of making peritomy and Hoffman's pocket or a scleral flap, the needle is, the suture 60 Prolene or 70 Prolene is threaded through the needle. It is exteriorized. The other end of the needle is passed through the eyelet of the CTS, and the suture is flanged till it becomes larger than the eyelet, and then it is positioned. The sutures are trimmed, flanged, and then buried. So it's a much simpler procedure compared to the traditional procedure where we have to do a lot of peritomy, flaps, and stuff. Why is it not coming? So the second indication where we, excuse me, it's not playing. How do you play? The second indication where we use this is in iridodialysis repair. So it's a similar case of traumatic cataract where phaco is done. The iris is anchored first using a hook, and then high molecular weight viscoelastic is used to flatten the iris. The iridodialysis position is identified, the points are marked, and then using a long spatulated needle attached to 70 Prolene suture, it is passed through the ab interno inside the eye through the peripheral iris. It is brought out of the main tunnel, and again with the same needle a U-turn is made and it is passed inside, and it is exteriorized ab interno. And similarly, once the proper when you pull the sutures on the exterior, proper approximation is achieved. The sutures are trimmed, flanged, and then buried. So third indication is where we do a scleral fixated lens. It's a similar where deep anterior vitrectomy is done after nucleus delivery. The needle is passed on either side. It is exteriorized. And the new thing what we do is you use a regular PMMA lens, a single piece or 3-piece PMMA lens. With the dialing hole, we pass the suture from above to below and flange it so that it becomes larger than the dialing hole. It is interiorized, and the sutures on the exterior are pulled, trimmed, flanged, and then buried. So this is as simple as that. So the advantages of this flanges is that no peritomy, no flaps, no minimal sclerotomies, less time consuming, and the learning curve is much easier. But this is what I mainly wanted to discuss. The concerns with flanges are there are so many reports and articles on endophthalmitis due to suture tract infection because the conjunctiva, sclera, the sclerotomy being directly from the conjunctiva and sclera. The second one is the flange dislocation because the sclerotomy being large, and then conjunctival erosion because the flange is too large. To plug a large sclerotomy, we have to flange a lot of suture so that it is much thicker and it can cause conjunctival erosion. So to overcome these challenges, to overcome the scleral tract infection, the first one is to move the conjunctiva radially towards the limbus before making the sclerotomy, as shown in this image. So we ideally position the needle at the point where we have to make the sclerotomy, and using a tooth forceps, we gently hold the conjunctiva along with the tenons, move it towards the limbus, and then make the sclerotomy, as shown in this animation. And then once the fixation is done, at the end you will see that intact conjunctiva is over the flanges and not there is no direct opening to the sky. So this is one of the things that we found out. And then the second one is we initially started with a 26 gauge needle, then moved on to a 30 gauge needle, and then now we use a spatulated needle. So this is a 16 mm needle which we designed attached to a 70 Prolene suture to reduce the size of sclerotomy and the amount of suture to be flanged as well. So the needle type comparison is when you make an incision with a spatulated needle, it is around 250 to 120 microns. in dimensions, whereas when you use a 26 gauge needle, it is an irregular circular 400 micron in diameter. It is a circular, very large opening, and the 30 gauge needle opening is 340 microns. So with this new needle, we've had 0 cases of slippage or flange related complications, whereas with the 26 gauge, we've had 2 cases of flange dislocation. And the amount of suture is also like 3.5 mm of suture was required, but now only 1 to 1.5 millimeter of suture is required to create the flange. To the amount of suture, the length of suture that we have to cauterize is just 1 to 1.5 millimeter. And most importantly, the last part, with the spatulated needle, the gram force required to puncture the tissue is around 46 gram force, whereas with the 26 gauge needle, it is around 96, it is almost double, and with the 30 gauge, it is around 87. So this, in a post-vitrectomized eye, when the eye is going to be soft, if you are going to use too much force, there is a high chance you can induce traction. Later on, it can lead to RD. Whereas with our needle, it is much more thinner, the needle that we designed, and it is much more easier to penetrate, causing less traction. Thank you very much.
Vivekanandan, wonderful. You put the whole thing in one basket and gave it as a bouquet. So you have a needle that's perfect, and the technique that you're trying to do by moving the conjunctiva is perfect. So it does make a very good thing. But finally, what are the complications that you come across? You've done a large number. There must be some complications.
So initially with the 26 gauge needle.
With the final product.
The only problem is when the first flange is, if you do not center properly and flange, the first flange is a little bit off. If it is a little bit loose, you can again pull the suture, flange it. But if it is a little bit tight, you'll have mild decentration with the SFIOL thing. That is the only challenge, sir. But there will be now no tilt. Instead, there will be decentration. Okay. If it is going to be within the pupillary area, it does not create any problems.
Okay. I think.
Excellent presentation, Vivek. I know you're a very big fan of Prolene and flanges. See, if you're doing something like an irododialysis, you need not really pull it up and make it very tight.
Yes,
because some amount of redundancy is acceptable.
It's a little bit loose. We're not supposed to pull it.
In a scleral fixation or when you're fixing the bag, how do you assess how much redundancy is there? Because for the flange to exteriorize, especially when your entry is small, if you have more redundancy, there'll be more exteriorization. You understand? If there's more loose flange inside the eye, more chance it will push out.
Yes.
Unless it really goes and fits into the scleral pocket.
You have to plug it.
How do you manage that? How do you assess that redundancy intraoperatively? Because postoperatively, you can always see and say, yes, this is more redundant. But intraoperatively, how do you assess behind the iris?
Yes. So intraoperatively, initially we had cases where there was tilting on one side, deepening. So we were the other point is we are placing the IOL 0.5 diopters a little bit higher than the usual. So after positioning the IOL inside, both the sutures on the exterior coming out of the sclerotomy is stretched, sir. When it pulls, what happens? The flange inside the eye, which is plugging the IOL, will automatically plug the dialing holes, and then it stays there. What we have seen is, I do not know the explanation, but when we stretch, it comes to a position and it stays there. That stretching part is very important to keep a flat IOL without tilting at the end. And the idea is not to tighten the suture, sir, not to stretch the suture. It has to be exactly the same length. So mild decentration for the first flanging is done because the forceps what we are holding, we want to compensate that distance. The second flange, you do not try to center the IOL, because if it is a little bit off, you do not try to. If you have to center it, you have to redo the entire procedure. Otherwise, accept or leave the IOL as such, and we indent the sclera before flanging. Because if you are not going to indent the sclera, that forceps distance is going to be there. So what I tell all my residents is, you position the suture, the forceps on the sclera, press on the sclera a little bit, hold it. Another important thing I tell them is always form the anterior chamber tightly before doing the flange so that it is not loose or tight.
You were using 3.5 and now you're using 1.5 to create the flange. Why was that difference?
So, madam, initially we were using 26 gauge needle. When the sclerotomy with the 26 gauge needle, it is very clear cut. You can see a small round opening. So with our needle, the needle that we are using right now is 200 microns, and the incision, whatever we've done, we've done 10 incisions on the dry lab and we've measured. So it is roughly somewhere between 200 to 250 into 120 microns. So it is a small slit. So to plug that sclerotomy, we don't have to flange 3.5 millimeters of suture. So 1 to 1.5 is more than enough.
And because what is the diameter of the flange head? Would you know
that? I have not measured, madam, but 1 to 1.5 mm of suture is what we have measured. Okay. It is just a small dot. The other advantage is there is no elevation on the tear film, madam. Little bit.
Little bit bigger because when with the 29 and the 30 gauge, the flange it is pretty large.
Yes, ma'am.
And so many times, if it's not a smooth
You
head,
the
you can see
tear
it,
film is
yeah,
elevated.
and not only the conjunctiva can be eroded as well.
Yes, madam.
So
Yes,
that's the reason. If it's a smaller one, the chances are much lesser.
It's much safer.
Yeah.
That's why we moved from 26 to this.
Fantastic. Thank you.
Thank you. Thank you.
Thank you, Dr. Vivek. You can collect your certificate from Arul sir.
Next, I invite Dr. Prasanna Venkatesh Ramesh to present an innovative, self-built, cost-effective and patent-protected 4D holographic ophthalmic metaverse. The judge for this is Dr. Preetham Samant, sir.
Thank you for the opportunity. So mine is a metaverse that has been done cost effectively. So this is a patent protected technology that I would like to share. So last year we were able to crack in the 4th dimension. So we invented the holograms at our center and we were able to make sure that the examinations were done in 4th dimension. As you can see, my friend on the right is examining the patient with the holograms and the headset. So this is a NTG glaucoma, as well as you can see another patient which has RNFL defect. So we were able to crack the holograms on a 4th dimension level with the VR or the AR headset or the mixed reality headset that we would like to call. But there were many limitations with the headset because it was not really kicking off as the way we wanted to. So in a country like India, nothing reaches like in a smartphone. So we had to reinvent ourselves with the LiDAR technology. So we had to make sure that to reach the masses, we had to go to the smartphone. And this is the QR code that we have innovated, and it's more like an EMR as well as for teaching. So I call it the subtractive ophthalmic learning. You can see the buttons on the bottom here. So once the patient's data is scanned, you can see that the template has been created. So once you click the button, the different subtraction happens. So if you want to remove a particular structure, if you're having a neuro-ophthalmic practice or for the ophthalmology as well, you can use different filters like ASOCT, ultrasound, or you want to use any ophthalmic. It's a translational software basically. So we have given the buttons below and it can be done by tactile dissection. All you need to do is use your phone with your fingers. You can do tactile dissection, or you can use an augmented reality module as you can see on the right. On the left hand side, you can use your fingers as buttons, or on the right hand side, you can see, you can click the smartphone, you can use your LiDAR technology, and you can see that the template is there on your table. Like wherever you are, you can just need to focus on any particular thing. You just need to open your camera. And also we have worked on a 3D smartphone simulator. You just need to move your phone like a fundus ophthalmoscope. It can be used as a simulator. There are a lot of advantages with this, with dexterity and other things. We see the scope in pedagogy, in simulators, as well as having your own ophthalmic case sheets of the patients as EMR as well. So we have currently worked on that as well, which I'll be showing. So this is the right hand side. You can see that once a patient has been examined for a fundus or a OCT or for any examination, even an gonioscopic picture per se, automatically it gets filled into this template. So that is the software that we have innovated. So this is how we created the template. The template creating was the more tougher part because we had to make sure that the template had to be created slightly differently compared to the one that we had for the headset, which we had to now reinvent back for the smartphone, because smartphone we felt reached more masses than the headset, because headset was not really kicking in. Jio never launched its Jio headsets. So now you can see these are the amalgamation of patients' data that we start collecting in our OPD. You can use different filters in the fundus. You can use a red-free filter. You can use a different kind of filters, and you can also use these for counseling, my dear friends. Even for AIOC PI counseling, it is all available in 3D. At the end of the day, if the patient downloads a particular app, individually the patient can be customized for his particular app. So we don't need to attach a printer or something. A 3-dimensional case sheet. You can see this is the workflow that we have currently cracked. A patient walks in, you do certain examinations like a fundus or OCT. It goes into our database. It's a translational software. Under 60 seconds, a hologram is created. It's currently under alpha testing, but we should be able to crack this on an EMR level as well. where there will be a 3-dimensional or a 4-dimensional EMR, where you can also see just in your smartphone, you can focus on this. You can extrapolate the OCT also out of it, because we have coded on that level that even it can be superimposed even on anterior segment images as well. I personally believe, and this is published recently in 2023 in the European Journal of Ophthalmology, and this we call fondly the ophthalmic metaverse, and we have made sure we never leave any blind spot in the patient's case sheet or for counseling or for simulation. So this is my team, and thank you once again for this opportunity.
Yeah. It's a really wonderful, innovative technology. First, my question is like to know about your background. How come you are so well versed with these raw technological things?
Sir, I
it's
scored,
really very, very difficult for a doctor to do such kind of things.
Sir, I scored 199.75 was my engineering cutoff, sir. But my dad put me into honest answer, sir. He's
So,
here.
yeah.
Sir, he
So-
did not even allow me to put counseling for Anna University, sir. Otherwise, I would have escaped.
Yeah. So previously you was a wrong man for a profession, but now you have become or converted yourself to a
Yes, sir.
right man for the profession. So
Yes,
where
sir.
there was lacuna, you are introduced in.
So, but I
it-
always had this passion for the Iron Man as well as Blade Runner 2049. But now I'm loving my specialty. I'm a glaucoma person. I love my specialty. I'm trying to marry ophthalmology with technology, sir. No, I. No, ma'am.
it seems to be path breaking actually. I don't think any such thing or any of the parallels are there in the technology right now. So
Yes, sir. Currently in literature, metaverse, we were able to crack it in the 4th dimension, sir. That is with the headset. But that never really picked off, sir. But with this app, many downloads have increased. And even when I had a discussion with Arulmali Varman, sir, he was the one who gave this idea on EMR. So currently we are working on EMR as well with this technology, sir.
have you launched it commercially also?
Sir,
or
it is available. It is available today, sir. The QR code, or you can type IMG Max, EYE space MG space Max. If you have an Android, Apple or an Android phone, you can type that today in the App Store. It's for 3 days. We have given it free of cost, sir. It's on trial, and after that it will be chargeable. Now it is available for teaching and counseling. But since the EMR is in the alpha testing stage, for this software to really work, we have to do some more efforts so that it can work in everybody's hands for an EMR level. Yeah. Yes, sir.
So you have opened up a sea of opportunity. Actually, it's really,
Yes.
really wonderful in my opinion.
Will it be helpful for the DR screening?
Sir, screening per se, it will be helpful, sir. But this is not a imaging tool. This is a translational tool.
Okay.
So for a DR screening, again, it is not going to replace an imaging modality.
Right.
But if you have a good imaging system somewhere where you have fundus, OCT, and you have so many imaging modalities, they can send you. Personally, I feel when the patient takes a case sheet and gives in a 2-dimensional plane, sometimes it may not be maintained well. But if I'm referring somebody, there is a 3-dimensional case sheet, I feel that we are doing good for the doctor who the patient is going to see next, because he can see exactly the way the things are, is what I envision, sir.
Okay. Thank you.
Thank you, ma'am. Thank you, sir.
Thank you, Dr. Prasanna. And the next speaker would be Dr. Prashant, who will be. Dr. Prashant will be presenting his innovation.
App Store readily available. App Store.
No.
Android.
I can see. It's not.
I'll install and leave it. It's an Apple phone. It's an Android phone. You have to type it. Yeah. Oh, sorry. I'm really sorry. My personal number. Yes, sir. Rishi said that I didn't update my address in the AIOS portal.
HTML is not recognizing.
My personal. I'll do it. Yes, sir.
With electronic medical records, medical imaging, healthcare data management, healthcare analytics, biology, informatics, and population-based health. Today, I'll be focusing a little more on the mobile health applications, remote monitoring, and telemedicine. As we know, smartphone-based apps have been coming into a lot of us today. This app deals with monitoring of a patient vitals, a medication reminder, a telemedicine, a lab test booking, and a home care booking. Now, as we know, in smartphones, telemedicine is an easy to access. It saves healthcare cost, non-adherence to treatment, personalized patient engagement, and a better quality care. One of the reasons why I had to, make an application is also because of the challenges faced. As today, we see so many patients coming with uncontrollable diabetes and hypertension. We have patients coming with compliance of medications, which has already been highlighted in glaucoma, access to doctors and follow-up checkups, disabled patients who are not able to come for checkups, senior citizens and long travel to hospitals. This is the application Remote Health app. As you can see, once you download the app, there is a small registration they do with the name, email ID, and the mobile number. So this will help to create a validation of a unique ID for the patients. An OTP is come to the requested mobile number. And once the passcode is come and entered, the patient can get authenticated into the app. So once they log into the app application, this is a small profile where the patient fills up his history and details. Like once he fills his name and age, he has a few history that he is going to write in the app, which probably will be his details of his medications, any history of any blood pressure, cardiac diseases, and diabetes, any drug allergies. Once he has entered that, he can also add the family members in a single app, his brother, his grandparents, and it also can help to document a few health records if he wants to take and document it. Now we come to an interesting part, which is the health vitals. For most of the patients who use devices and have home check, they can enter their vitals in the house. And this is very important in patients monitoring for diabetes and hypertension. Here you can see the vital chart where he can enter his weight, calculating his BMI with the height, any temperatures, pulse rate, the heart rate, the SpO2.
Now I will show you.
And once the vitals are entered, you can also have a pain scoring.
It is added. I will show you the graphical chart.
There is a chart where he could see his timeline of the vitals on the last 3 months. So this is where the vital chart can help to understand where the spikes of the diabetic or the blood pressure has taken place. And here you can see the wearable devices which can be linked to the app. And this is a medication reminder app. Today, we all know what is the compliance of medications in glaucoma. So here we have a medication app where we can set the medication, the start and end time, the dosage, the frequency, and when to take the medications before and after food, and a few instructions are given below. You can see on the left side, I'm scrolling down the app. It asks every day, once daily or twice, the time in which the medication can be setted. One second. So once he sets the ringtone, and finally you can see how the reminder will come on the screen. And once he clicks taken, which shows that the medication has been taken. So once you click the button here in the screen, he can download the file and share it to the doctor and see the number of places and times that he has taken and not taken the medication. So this is very assuring to the patient for the compliance. The other is a doctor consultation, where the patient can book an appointment with the doctor, where he can type a few complaints, any other symptoms, and the vitals, of course, if there is any past medical history, the current medications, and then drug allergies. And then finally, he can book a doctor with the appointment time and schedule. And this is how the doctor chart will be. The doctor has a login ID, where the doctor receives the appointments and sees the consultations. He sees the completed appointments, and then he can join the call at the time required. And the doctor can see the patient's history and data if entered, his previous histories of allergies, and he can also ask for laboratory investigations. And he can also give a prescription for the patient. And this is a lab diagnostic booking, where he can book for the lab testings in case that the doctor has advised. There could be a home collector which comes. And this is a home care booking, which also books for the home care services at home. So finally, in the future, we're also looking at the remote monitoring of patient integrating wearable devices, pediatric monitoring of patching therapies, an optometrist app which could be integrated for screening and eye checks, a vision chart for self-test, and an AI integrated analysis. Thank you. Yes, sir. Yes, it's a one-stop solution so that the patient can use all these applications in single app.
The patient is to pay anything for that?
As of now, there is no payment. As if at all the patient needs for the consultation, yes, there could be some charges which the doctor has pre-booked, kept in the appointment.
Can we monitor also?
Yes, we can monitor the patient's vitals. And of course, with our wearable devices, you can have a real-time monitoring, which could be shared to the doctor after the patient checks. But of course, for real-time monitoring, you need a separate, application which can monitor in real time. But this could be recorded, then probably transmitted by a PDF file.
Is it area-wise or region-wise or state-wise?
No,
universal?
It is universal. The region-wise could be probably for the lab booking, which region the lab is there, and that lab could be tied up, and which services of home care is there around that area, which could be tied up for that.
Okay, thank you.
Thank you, doctor.
So basically, you need doctors and the labs to join your network, and then only it can be provided to the patient.
Yes.
So it's a kind
if
of.
The doctors can join, or they can also use it as they are to follow up their own patients.
So there are various apps available in the market, similar kind of telemedicine and other things. So how does your app is different from them?
So in this app, you would have seen there is this vital monitoring, which has the vital graphs, which is recording over a period of time on the patients, so that early intervention could be created in terms of any spike and uncontrollable diabetes. There's a medication reminder. Normally, you may have a medication reminder, but here it is an online medication reminder which tracks every time the patient clicks taken, so that you know the compliance of the patient. So this creates an assurance of the patients to see that the patient has been taking the drops. One of the two highlighting features in that. And we have a home care which is collected to the regularized area.
So from what I gather, the patient has to have the app installed to take an appointment and then fill in the history.
Yes.
Wouldn't it be more easier if the whole appointment system and the history was through a chatbot on WhatsApp, which will later populate your software?
It can get integrated to the software, but if you want to get some kind of a health record into a system, you need to have it through a kind of a module of an app, rather than you can integrate the WhatsApp data into this app also if required.
No, but why would you necessitate for the patient, every patient to download our app? That's my question.
Because the data of the patient, what is recorded, is going to be stored in the app.
Okay.
In WhatsApp, we don't have the credibility for that, right? That's number one. And there is an additional feature in this, which is a reception app, which I've told you, where the reception or the secretary of the doctor can book the appointments for the patients in terms of follow-up. So the doctor or patient need not have the burden of booking the appointment. It could be booked by the reception itself. Thank you, sir.
I request Dr. BNR Subudhi sir to give present the certificate. Thanks to all the presenters and judges. Thank you.